Hello everyone. Welcome to second video lecture session of topic epilepsy. Hope you have seen first video of topic epilepsy. In first video we discussed about basic things of epilepsy, various types of epilepsy, generalized, focal, then subtypes of generalized epilepsy and partial epilepsy, and then we discussed about the classification, especially classification based on mechanism, which was more important to understand mechanism of action. So based on these two figures, drugs enhancing GABA and drugs inhibiting glutamate. So once you have understood this much, in today's lecture video we will discuss about individual drugs and then common principles of epilepsy treatment, right? So in individual drug we will discuss about the highlight points of individual drugs, especially which are more commonly used drugs, right? Okay, so let's start with the first drug, that is phenytoin. Now, phenytoin is one of the oldest drugs which is still used in epilepsy. Still, it is the first line management drug for the epilepsy, right? Along with the newer drugs. So basically, phenytoin is a drug. It has also prodrug that is known as fosphenytoin, and both are used, right, in the different type of epilepsies. Now, in every drug, as we have discussed mechanism of action, and this both the figures, all the mechanism of actions we have discussed. For example, let's take mechanism of action of phenytoin. So here we have discussed that phenytoin that inhibits this sodium channel, right? Voltage gated sodium channel is being inhibited by phenytoin. So with each individual drug will not discuss mechanism of action now. We'll discuss uses and other aspects of that particular drug, right? Okay, so phenytoin, uses of phenytoin. So the drugs which are used in treatment of epilepsy, they have use in epilepsy also, and some other non-epileptic uses also. So we'll discuss both the uses. So basically phenytoin is used in partial seizure, GTCS, that is generalized tonic-clonic seizures, right? And that is status epilepticus. SE means status epilepticus. We'll discuss status epilepticus separately also, but these are the three major types of epilepsy in which phenytoin is used. It is not used in absence seizure, right? And also in myoclonic seizure also it is not used. In non-epileptic uses, it is used in trigeminal neuralgia, which is a nervous system related condition where trigeminal nerve get inflamed, and so in that management it is used. It is also used in ventricular arrhythmia, which is due to digitalis. In that condition we have other drugs also, but phenytoin can be used, and it has also shown some role in wound healing also, but not much use in that uses. Okay, now pharmacokinetic prospects. It is not given IM or IV, right? It is given orally. Its prodrug, that is fosphenytoin, it can be given by parenteral route, right? But phenytoin itself cannot be given by IM or IV. It has to be given orally only. Now this particular drug phenytoin, it is therapeutic monitoring is very important for this drug. If you recall the general pharmacology, we have learned this aspect: therapeutic monitoring, therapeutic index, then next mix order kinetics, all we have discussed at that time. You must have come across the example of phenytoin also, means drug following mix order kinetic, example phenytoin. So at that time you may not have correlated, but now as we are learning this drug, focus on this, that use of phenytoin requires therapeutic monitoring. Now what is therapeutic monitoring? You have to monitor its plasma level, that what is the plasma level of phenytoin. Usually the normal plasma level of this phenytoin is 10 to 20 microgram per ml. So if patient is maintaining this level, then usually consider that it is safe. Now this kind of treatment, anti-epileptic treatment, requires lifelong treatment, right? It is not that you have given for the 1 month and patient is cured. So it requires lifetime management. So drug has to be given lifetime. Now once drug has to be given lifetime, if the drug is safe enough, then it's okay, monitoring is not required. But if drug is having some such kind of pharmacokinetic profile, then therapeutic monitoring is must. All right, so 10 to 20 microgram per ml is the maintained level of phenytoin. If it is more than 20 microgram, then it can lead to toxicity. Now what is the reason that it is requiring therapeutic monitoring? That is, it is following mixed order kinetics. Means that at the initial level it will follow zero order kinetics, right? And if slight dose is increased, then it will shift. Means if sorry, it was a switch off. Initially it follows first order kinetics, and if concentration increases, then it follows zero order kinetics. Because initially what happens in the first order kinetics, if you remember, that is fixed fraction of plasma is eliminated. So in that case half life will remain constant, right? So when, as far as it is following first order kinetic, there will not be problem. But at the increased dose or the longer time of duration, it will start on following zero order kinetics, where plasma half life is not constant, right? So it may show increased concentration with the same dose which patient was taking previously. So there are high chances of toxicity is there. So periodic assessment of plasma concentration is very important. However, clinically nowadays they don't much follow this plasma concentration. Either they switch on to some safer drug, or usually they follow clinical profile of the patient. But following plasma concentration is the safer side, right? It is having half-life of 24 hours, so longer duration of action. So once the patient is on drug, right, as the half-life is 24 hours, so usually 4 to 5 half-life પછી peak concentration આવે, right? So once you give the drugs, it will take minimum 5 days to take effect. Now the epilepsy is most of the time, at the first time patient comes in emergency, right? So at that time if you give oral phenytoin, the single dose will not help, because the maximum concentration will require 5 days time, right? So at that time you can go for loading dose, right, or some IV drug given, then you can switch on to phenytoin orally. So these are clinically important pharmacokinetic points. Now coming to adverse effects. Now adverse effects of phenytoin are also important, as it is very peculiar, very typical type, right? Okay, one is the overdose toxicity. That means that if you are given the dose more than required, in such case patient will have some CNS side effect like depression, nystagmus, right, lethargy, blurring of vision. But that is overdose. If patient himself have taken overdose, or you have given overdose, whatever. Okay, but that is very uncommon type. The most common type is dose related chronic toxicity. Means that toxicity that develops once the patient have taken drugs for a longer time. In that side effects, one is gingival hyperplasia, for which I have shown one photograph. It shows gingival hyperplasia. That is because phenytoin, it inhibits collagenase, right? Collagenase, which is responsible for breakdown of collagen connective tissue. So it inhibits collagenase, so collagen will not break down and that will get accumulate and that will lead to gingival hyperplasia, right? Coarsening of facial features will be there, that will also be due to same reason, inhibition of collagenase enzyme. Then megaloblastic anemia. Megaloblastic anemia occurs due to folic acid deficiency. Now what phenytoin does is that it enhances enzymatic activity in the body which requires folic acid, right? So all the enzymatic activities which requires folic acid will get enhanced in the influence of phenytoin. That's why when patient is taking phenytoin, there will be folic acid deficiency and that will lead to megaloblastic anemia. Then it also causes vitamin D and vitamin K deficiency, right? So vitamin K deficiency, the patient will get reflected by hypoprothrombinemia, and if mother has taken phenytoin, then newborn may develop hemorrhage. So such kind of effect can be seen. So you can give vitamin K supplementation for that. Phenytoin also leads to vitamin D deficiency by increasing calciferol metabolism. It increases calciferol metabolism and that leads to vitamin D deficiency, right? So it can lead to symptoms of vitamin D deficiency in the patient. So both the supplements are required, vitamin D and vitamin K, especially in suspected patients. Hirsutism, that you all know, in female, development, growing of hair, that can result due to stimulation of androgens, right? Then there can be increasing, there is a one mistake, I guess, that is not a hypoglycemia, it is hyperglycemia. So please consider it as a hyperglycemia. It causes hyperglycemia, not the hypoglycemia, right? Okay, because it decreases insulin secretion, that's why it causes hyperglycemia. Okay, then it can decrease ADH secretion, but that is very rare. This side effects is very important. This teratogenicity is very important. Congenital malformation, right? If given during pregnancy, the resulting generation can have congenital malformation like cleft lip, cleft palate, right, or congenital heart disease also. So this kind of congenital malformation can result. That's why they are contraindicated during pregnancy. But important thing is they are not absolutely contraindicated. Why absolutely not contraindicated? Because if suppose mother is having epilepsy and with the fear of congenital malformation, we are not giving anti-epileptic drug, this particular suppose anti-epileptic drug. Now if during pregnancy episode of epilepsy comes, then anyhow it will be fatal to the fetus. That epileptic episode itself will be fatal to the fetus, because rigorous muscle contraction, uterus muscle contraction also, fetus may even die, right? So avoiding anti-epileptic drugs is not the option. The option is choose safer option, right? We'll discuss other drugs are there which are comparatively safer. But if at all safer drugs are not working and you require this danger drug to be given, then also better is to give rather than avoiding. Okay, then hypersensitivity reactions which can occur in any drug. Withdrawal seizures, this is important. If the patient is on long-term anti-epileptic treatment, phenytoin, if you discontinue it suddenly, due to discontinuation there will be withdrawal discharge from the neurons and that will lead to epileptic attacks. So always discontinuation requires tapering. You have to taper the dose gradually and then you have to stop, right? Even if you are switching on to another drug, then parallel you have to taper this and on the next drug you can gradually increase the dose. So that is always required. Okay, So once we have discussed the uses, coming to next uses and side effects, coming to next drug, that is phenobarbital and primidone. Okay, now in each drug we'll not discuss mechanism of action, we'll discuss uses and this adverse effects only. It will uses of phenobarbital and primidone, they are used mostly in this partial seizures and GTCS. Additional use is that they can be used in prophylaxis of febrile seizures also. Febrile seizures we have discussed earlier, that is in the children usually less than 5 years of age, where there is seizure associated with the fever, right? So it is used for the prophylaxis of febrile seizures. Okay, adverse effects like phenytoin, phenobarbital and primidone are not showing that kind of very broad range of typical side effects, but can cause irritability and hyperexcitability, and this drug is also teratogenic, so avoided during pregnancy. Then carbamazepine and oxcarbamazepine, they are first choice for partial and GTCS, right? Again, like phenytoin, they are contraindicated in absence seizure. Like phenytoin, they are used in trigeminal neuralgia also and other manic depressive psychosis. Now, like phenytoin, it also requires plasma concentration monitoring, where the normal level is 4 to 8 microgram per ml. So excessive dosing will lead to excess plasma concentration, and that can give rise to toxicity, so that is important. Adverse effects of carbamazepine, general CNS side effects can be seen. Allergy, it stimulates ADH, and it is also teratogenic. So you have seen all these three drugs which are commonly used for GTCS and partial seizure, they all are teratogenic, right? Okay, we'll discuss main points only of important drug, because the details means that it just carries theoretical details only. Okay, next is ethosuximide. It is used in petit mal, or you can say absence seizure. It is a drug of choice in absence seizure. We have discussed earlier ethosuximide and valproate, they are used. So it is, that's why it is known as pure petit mal drug, because it is first choice for absence seizure given orally. Adverse effects are common adverse effects. Usually it is safer drug, it doesn't cause serious side effects like phenytoin and phenobarbital, plus it is also safe in pregnancy also, right? So absence seizure you can give safely ethosuximide to the pregnant woman also. Okay, now next important drug here we have is valproate or valproic acid. Now after phenytoin, it is the second most common drug that is commonly used. It is older also and still commonly used for epilepsy. Second thing, it is broad spectrum. Why it is broad spectrum? If you remember the mechanism of action, I told you that some drugs have multiple sites of actions, right? So that was valproic acid was one of them. It also blocks sodium channels, it increases GABA activity, right, by activating this glutamic acid decarboxylase, and by inhibiting GABA transaminase both, and it also inhibits type T calcium channels. If you remember this figure here, here also site of action of this valproate, right? Then here GABA transaminase inhibition also by valproate. Here you can see the valproate. So it has multiple sites of, here also sodium channel. So multiple sites of action. That's why it is broad spectrum, can be used in multiple types of epilepsies, right? So it can be used in absence seizure because it is blocking calcium channel. it is blocking sodium channel, so can be used in GTCAs and myoclonic seizures, can be used in partial seizures also. See other types of epilepsies also, Lennox-Gastaut syndrome. Now this particular type of epilepsy, we have discussed syndrome classification, right? So in that classification, such type of sub syndromes of epilepsy comes. So Lennox-Gastaut is one of them. It is usually seen in children, and it is associated with cognitive impairment, right? The child will have epilepsy also with cognitive impairment. Usually epilepsy સાથે cognitive impairment hoy, it is not necessary, mostly not seen. Intellectually patient will be fine. So here in this type of epilepsy, the child will have epilepsy plus cognitive impairment. So Lennox-Gastaut syndrome, in that valproate is used. Infantile spasm, that also we have discussed. This is very rare, peculiar type, tonic-clonic conversion as well, but the prognosis is very poor, right? So in that management of infantile spasm, can use valproic acid because it is broad spectrum. Okay, then again it is used for prophylaxis of migraine. If migraine હજી બાકી છે આપણે, but એમાં આવશે prophylaxis માં this is used. Okay, other uses, Cushing syndrome, tardive dyskinesia and trigeminal neuralgia. So these are the non-epileptic uses of valproate. Now in case of valproate also, you require therapeutic plasma monitoring is must. You have to monitor because it can also cause dose related toxicities. Okay, then adverse effects ni andar we can see dose related, means જે આપણે general CNS toxicity plus the general nausea, vomiting, tremor, like that toxicity, dose related can be seen. One of the important thing is it is hepatotoxic, right? So in long term use, monitoring of lipid hepatic profile is required. It can also cause pancreatitis. If given to pregnant women, it can cause neural tube defect and spina bifida and fetus, right? Okay, now if you have observed one thing, the greater the spectrum or greater the utilization, more is the adverse effect. That is the common thing in all anti-epileptic drugs. Later in the same video we'll discuss about newer epileptic drugs which are safer, but at the same time they are not potent, right? So these are valproate, phenytoin, these are very potent and very effective, but at the same time having very dangerous adverse effect profile. So keep it in mind. Okay, benzodiazepines, we have discussed mechanism of action. We will just discuss important points. Lorazepam, diazepam, clonazepam are commonly used. Amongst that, lorazepam, it is given IV, and it is the first drug that you should give in the management of status epilepticus, which is the emergency, or obviously all the epilepsy are emergency, but if epilepsy continues without stopping the attack, then it is status epilepticus. In that, lorazepam is the first choice of drug. Then you can give diazepam and clonazepam also. Only one thing that is you can say it is that prevent the use of benzodiazepine is they are less effective than the main drug, and second thing, they are more sedating. So all the patients will have sedation as the side effect. Okay, now coming to newer epileptic drugs, as just we discussed that these newer epileptic drugs, they have invented later, and they are having less side effects compared to the older drug, but at the same time they are less potent. So still they are not the first line of drug. They are always used as an add-on therapy to the older drugs, right? If patient is not well managed by phenytoin, you can add one of these newer drugs, right? That is all. So in this we have vigabatrin. We have also discussed mechanism of all these drugs also in that two figures. So we'll just discuss use and important side effects. Vigabatrin that are used for simple and complex partial seizures with some minor side effects like behavioral changes, sedation, and visual field defects. Tiagabine that is used for partial complex seizure and generalized side effects are there, not some typical side effects. Gabapentin and pregabalin. Now this gabapentin and pregabalin, they are you can say from amongst the newer drugs. It is more these two are very commonly used nowadays. They are used for resistant partial and GTCS, means the patient is not responding to phenytoin or patient is on phenytoin for the longer time and now patient has developed resistance, then you can start gabapentin and pregabalin. They are very effective, right? So they are also used for other uses are also there, like for example neuropathy, especially related to diabetic, right? Diabetes patient, long term patient diabetes per hoy, then they develop peripheral neuropathies and pain associated with that. So these two drugs are used commonly. Post herpetic neuralgia, that is again a pain after herpes, which is very painful condition, and pain with multiple sclerosis, which is also painful condition. So in this nerve related pain conditions, these two drugs are used. Topiramate used for GTCS, right, partial seizure, and Lennox-Gastaut syndrome. Zonisamide, it is comparatively broader spectrum. Lamotrigine is also broad spectrum, so used in multiple types of epilepsies, right? Felbamate is a wide spectrum also, and it also leads to aplastic anemia. Levetiracetam and locasamide both are used in partial seizure. So newer drugs we have just discussed where they are used, not going much detail in there because they are just theoretical points only, which you can read also. Okay, so we have seen the most commonly used drugs, important points of discussion about these drugs, and now we'll see about the common points which are used for epilepsy treatment. Before that, there is one non-pharmacological approach also, that is vagal nerve stimulation, right? So if you stimulate vagus nerve, right, it is believed that stimulating that will stimulate solitary nucleus in the brain, and that will change the neuronal transmission, and that will give relief to patient in epilepsy. But this approach is not very commonly used. Okay, now general consideration about the epileptic treatment. First, I also discussed this point also, that it provides only control, means by giving this drug you cannot treat the epilepsy, you can just control the episodes of epilepsy. Second, this point also we have discussed, that newer treatments are only add-on, right? Older are still the first line. Withdrawal effect, that point also we have discussed. Whenever you withdraw, that it must be by tapering, otherwise it can precipitate epilepsy. Then some catching points, that these drugs, phenytoin, phenobarbital, carbamazepine, and primidone, these all are enzyme inducer. Now if you remember general pharmacology, enzyme inducer will enhance metabolism of other drugs that can either decrease or increase the concentration of that drug, right? Especially drugs like oral contraceptive, right? So patient may have failure of oral contraception also, so that is important to keep in mind, right? So they are enzyme inducers. Then we have valproate, which is enzyme inhibitor. Phenytoin mixed order kinetic, we already discussed. Then this drug phenytoin, valproate, they are highly plasma protein bound. So clinical point of view, if the drug is highly plasma protein bound, they can displace other drug. So drug interaction chances are always there by using these two drugs. Pregnancy, we have discussed almost all the points on the pregnancy, that during pregnancy you must give the treatment of epilepsy, right? Choose the drug which is safer first, but patient is not in control, you have to give the first line drug also with minimum dose, so to prevent the epilepsy. Otherwise, epilepsy itself is the danger to the child. Okay. Second point is you have to initiate treatment early, right? Because the earlier the treatment, the lesser the neuronal damage. Because without treatment, with each episode of epilepsy, it will damage the brain. Neurons will get damaged. So initiate treatment as early as possible. Give combination only when single fails, right? If the single is working, do not add combination, right? If single is not working, then you can add on, especially newer treatment, the newer drugs, add-on treatment तरीके you can add. And if combination also fails, then generally adding third drug will not play much role. You have to switch on to some other mechanism of action drug with some other mechanism of action. So these are the general points which are to be kept in mind while treating epilepsy. Okay, now next, this is the conditions, special condition and treatment of that condition. Febrile convulsion we have discussed. With fever, child will have convulsion, right? Usually after 5 that will stop after age of 5, but during that you can give diazepam, which can be given rectally. Nowadays we have spray also, nasal spray are also available of other newer benzodiazepines, right? So you can give for that. Infantile spasm, anti-epileptic drugs like valproate are used, but steroids are used along with that for infantile spasm, very difficult to manage. Okay, now this condition status epilepticus that we have discussed, it is used, this drugs, this condition, it is actually an emergency condition which requires specific management. If the epileptic episode lasts longer, right, and if patient is not getting conscious in between the two attacks, right, then it should be considered as status epilepticus. For that we have to consider first airway, because there are during the laryngeal spasm the blockage of airway, chances of blockage of airway is there. So first control airway. Then second is correct hypoglycemia, because hypoglycemia, it can be also a reason for epileptic acid. So if hypoglycemia is there, correct that, then switch on to the treatment. The first drug you should give is lorazepam IV. If lorazepam is not available, then only you can give diazepam, otherwise lorazepam is the first choice, right? Then second you can go for fosphenytoin IV, that is the add-on, not the replacement of lorazepam. You can give fosphenytoin IV, and if fosphenytoin is not available, then you can go for phenobarbital. All the drugs are given parenterally, no oral treatment, because episodes are going on, you cannot give any drug orally, right? And general measles means IV hydration, that you are vital monitoring, that all you have to maintain during the attack of status epilepticus. Status epilepticus treatment अलगથી પણ એક્ઝામમાં પૂછાય છે, so focus on that, right? So that's all for epilepsy. In this we have discussed about general features about epilepsy, then individual drugs, and then about generalized management of epilepsy. Hope you have learned something from this. Within one day we'll post formative assessment of epilepsy also. Okay, thank you.